Thank you, Bill. Thank you, everyone, for coming. Looks like we're going to have another great course this year. So just to back up a little bit, Dr. Trenhill mentioned, I think, a very important point, which is the idea that success at the end of just about anything we do, especially surgery, is really predicated upon the successful completion of several small steps along the way. If you don't get the baseline steps correct, then your subsequent procedure is going to be off. We know that. That's probably true in just about anything we do in life. You guys may remember or may not Bloom's taxonomy, where the idea is it's a classification of objectives where higher levels of thinking and learning are predicated upon the lower levels. So the lower level thinking skills are just basically remembering stuff, memorizing stuff in medical school, and then you learn how to understand what those concepts mean, how to apply them, analyze them, evaluate them, and create, or basically innovate, is the top level of teaching. Well, we like to think that we're working around and analyzing, evaluating, and creating all the time, but in reality, it's very helpful to go back and recall and revisit our basic understanding of what we're doing and how we get there. And that's what this talk's going to be about. So OR setup, Dr. Trenhill did a great job of that. It can be really easy, especially if you're starting out and someone does it for you. But if you're doing it yourself, it can be quite difficult. So most of us that are experienced have our own situations that we've got set up. We've got our own patterns, and it may not be an issue. But there is some help out there. We spent some time on creating some videos that are accessible to anybody that can go over how to set up for a shoulder arthroscopy, say, in a very organized fashion in case you're struggling with that. It can be very difficult to change the atmosphere in a operating suite or a hospital. If they're used to doing things a certain way, it never works, and you've got a better way to introduce. So spend some time on maximizing your OR setup. So diagnostic shoulder arthroscopy, it really revolves around what procedures are you going to do. The surgical decisions that we make are really multifactorial. They're based on several different things. History is certainly one of them, the physical exam, the imaging that we have, knowing your patients. Some patients are going to be more amenable to some procedures than others. We know that. But then you're never going to get away from arthroscopic findings. They almost always are going to be involved in what we do in surgery. So while we try to minimize the amount of intraoperative decision-making we make, we're never going to completely eliminate it. Slap tears, biceps damage, partial rotator cuff tearing, glenoid bone loss. To a large degree, these are arthroscopic findings that go into our surgical decisions, and we've got to be aware of them when we get in there. And there it goes. So keeping an open mind is always going to be important. We don't want to miss important anatomy and have major effects on our shoulder. What we find is when we're in surgery, if you think you're going to see just something, the mind tells you it's there. If you don't think you're going to see something, you might miss it. So the idea of doing a diagnostic shoulder arthroscopy is predicated upon the idea that we go in with an open mind. We think we know and we're prepared, but we keep an open mind because we really just got one shot to get it right, and we don't want to miss major anatomic findings that are going to affect what we do. A diagnostic arthroscopy is done with the same technique every time. It's natural human tendencies to skip to the important part and get moving with your day because you're pretty sure what you're going to find. I would implore you not to do that. If it becomes the same brief, easy, and consistent technique that you do every time, it'll be much easier as time goes on. It'll become quite systematic. It'll minimize your surgeon bias. And if you take pictures and videos along the way, it'll be much easier post-operatively if any questions arise as to how the patient's doing after the surgery. So setup, positioning, and exam under anesthesia. These are those basic steps that Dr. Trenhill was remarking about. It's very important. It's part of your diagnostic arthroscopy. What do you see? What does the shoulder give you? Is it stiff? Is it loose? And then step one, really, of getting it right. If you set up your patient appropriately, you position everything correctly, that's step one of getting it right. But it's also step one of getting it wrong if you do it incorrectly. So pay attention to these details. So lateral and beach chair positioning, Dr. Trenhill went through very comprehensively. You can do a comprehensive arthroscopic access laterally. It's a little bit more limited in the beach chair position. Laterally, it's a very difficult conversion to an open if you're going to do an arthroscopic procedure and then convert to lateral, whereas beach chair, that's quite easy. Your hemodynamics are much safer in the lateral position than they are in the beach chair. It's more challenging orientation, though, in the lateral position than it is in the beach chair. Up is always up, and down is always down. Lateral, as we know, it can be quite different. Interestingly, we're learning that maybe there may be a lower recurrence rate after instability in the lateral position, but that's, at this point, still surgeon dependent, most likely. So, let's go back. So our landmarks, first portal, is going to be approximately 2 centimeters distal and 1 centimeter medial. Can we play that video? Can you guys click play on that video? So the first portal is going to be approximately 2 centimeters distal and 1 centimeter medial to the acromial corner. Attention to details make a big difference. Properly marking the skin of the acromion is going to be a very important thing to do so that we know exactly where we're going to start. Now, people's anatomy externally is quite different, so it's a good starting point to mark your surface anatomy, but it doesn't make your portals completely accurate. So our first posterior portal is going to be established before our anterior portal. Let me see if we can. It's an inside-out technique in most cases. And I'm going to need somebody to try to click on these videos because the advance button is not working on the videos. Alternatively, there's an outside-in access for a 2-portal anterior labral work. We'll use a spinal needle from the anterolateral aspect of the acromion and pop it in through the biceps or just the very top of the rotator interval. So when we're doing our 15-point exam, there's different ways to do it. As long as you cover everything, I think that we're going to be safe. So how do we ensure that we cover everything? Well, Steve Snyder has a good 15-point exam that we use. It's probably the most well-documented and easy to find reference. It's the most frequently used system. It's comprehensive, but it is a lot of points. We understand that. But we'll go through that because it's a good, consistent way to evaluate the shoulder. So points 1 through 10 is with the scope posterior. It's a somewhat serpiginous way of following yourself around the shoulder but basically we begin in the back, you go to the middle, and then you move to the front. So steps number 1 is going to be the biceps. We're going to grab the biceps, we're going to pull it into the shoulder. A point to make, we used to think that we could see all biceps pathology by grabbing it and pulling it into the shoulder. In fact, the more we look at it, the more we're learning we can't. We can see about maybe as little as 50% of biceps lesions when we do this. So keep in mind that an arthroscopic evaluation from within the joint is not guaranteed to show you all the biceps pathology. We have to be aware of slap lesions and their variants. Not all superior labral detachment is a symptomatic slap lesion, and that's going to be very important to recognize. If you look at it every single time, you'll realize the patterns that you'll see and what's normal and what isn't. So steps 2 and 3. Step 2 is the posterior labrum. We're going to follow ourselves around from the biceps, around posteriorly along the shoulder, along to the inferior aspect of the shoulder, where the axillary recess is going to be point number 3. Loose bodies, axillary recess, Hagel lesions, and often signs of adhesive capsulitis where you see a thickened red capsule in the axillary recess can be quite helpful. So the glenoid surface itself is step number 4. We're now working our way across the middle of the shoulder where we can evaluate the arthritis, presence thereof, as well as possible bone loss for instability. Steps 5, 6, and 7, now we're in the middle of the shoulder. It's going to be the anterior rotator cuff, supraspinatus, the posterior rotator cuff, infraspinatus, and then step 7 is going to be the humeral head. We'll be able to move the humeral head around, abduct, rotate, and look for chondral damage, Hill-Sachs lesions, and reverse Hill-Sachs lesions. Number 8 is going to be the subscapularis, the rotator interval, and the middle glenohumeral ligament. So now we're working down the front of the shoulder. We're going to evaluate the subscapularis and be aware of all the variants of the middle glenohumeral ligament, sublabral holes, Buford complexes. These are normal variants that should not be fixed. If you fix these normal variants, the shoulder will almost invariably get stiff, and you'll also probably miss the real cause of the pain. 9 and 10 is coming down the anterior aspect of the shoulder, the anterior labrum and the inferior capsule. And then we're going to switch sides, and we're going to go to the anterior viewing. So these are the last several steps, 11 through 15. We're going to start in the back, just like we did before, and move to the front. We're going to switch the scope around with a couple of switching sticks to make sure that we ensure our access. And then we'll slide the scope in to the front of the shoulder and evaluate the back. I can't stress enough how important this is. If you miss this step, you'll probably miss posterior labral tears, rago lesions, and a host of other anatomic findings that we need to know about. Viewing anteriorly, we're going to look at the posterior labrum and capsule first, work our way up to the posterior aspect of the rotator cuff at the top of the screen. And then we'll come around and look at the anterior inferior labrum. This is the view that is the most beneficial for instability surgery so that we can see our anterior inferior labrum and our anterior ligaments. We'll evaluate the middle glenohumeral ligament, the subscapularis as we come up. Loose bodies will commonly hide down here, so it's very important to get a good look at this down here in the subscapularis recess. And then follow our subscapularis laterally as far out as the humeral head and the biceps. So marker needles can be quite helpful as far as our diagnostic arthroscopy. They help us transition from pathology within the glenohumeral joint to in the subacromial space. I love using the marker needle that will pop inside the shoulder and localize the anterior aspect of the supraspinatus, and then enable us to find that same spot in the bursal position. I prefer the needle and leaving the needle into a suture. A needle is easily located in the bursa, and we can pop our scope and find the needle right there. And you also can't shave it with your shaver as soon as you get up into the subacromial space, so it can be quite helpful. Also, in moving from the glenohumeral joint into the subacromial space, what we'd like to do is slide your camera from the anterior aspect of the shoulder right up into the subacromial space. So a quick, smooth move can get you from the glenohumeral joint into the subacromial space. So if we see our needle here in the anterior aspect of the shoulder, we'll be able to slide our arthroscope from anterior up and out. We'll feel the rotator interval slide in front of us and then pop it up and into the subacromial space. Quick get our orientation, and then be able to go and find our spinal needle in the subacromial space and quickly evaluate the status of, say, the bursal side of the rotator cuff. So in summary, we don't want to skip the basics. We want to be consistent. You want to be systematic. You certainly want to be efficient. A good diagnostic arthroscopy takes 3 to 4 minutes tops. And you also want to be skeptical and not necessarily trust exactly what you think you're going to see, because sometimes you'll find that the truth is different than you thought. Thank you.